and she both had the biggest smile on their face when they saw me. It had been a while since I'd seen them, and she said, "Thank you so much. Everything's going really well. We have a really fulfilling love life." And I just thought, you beauty, good on you, well done. And that may not always be the case, but I do think that there's a good number of old people that are out there having intercourse and good on them. But to your point, it isn't for everybody. And I think on that point, I might, because it's a valid point, and we'll probably put the cart before the horse here to an extent. One of the main reasons that we do penile rehab is to ensure that we have an adequate amount of penis. So we know that doing penile rehab increases the length of the penis, and typically post prostatectomy the penis will be shorter anyway. And that's not unusual, and that's not unique to anyone in the room. So what we do know is that the penis ends up shorter after the operation invariably, and one of the reasons that we're doing penile rehab is actually to make the penis longer. And I shared with Jane an anecdote which I'll share with you about a gentleman who was referred to me. He would have been 5 years post-op, and he was at the point where he couldn't stand up and urinate because it dribbled down the front of him and it retracted so far. And when he sat down to urinate, it was so short that it sprayed out the toilet. So it was a very awkward position for him to be in. It was not pleasant, and he'd been referred to me by his urologist, whose name I won't mention, but and I was incredibly frustrated by that, because this gentleman had never heard about penile rehab. He'd never done anything, and he was left with this in this terrible position where he had no ability to clean and urinate, which poses all sorts of problems around hygiene and infection. So I think probably we have, to an extent, put the cart before the horse in terms of talking about erectile function. I think it's really important, but we also need to make sure that we're maintaining penile length. Does anybody on the panel want to talk about penile length? Yeah, Jane?
It's not really about penile length, but I think it's important that you realise that it probably, the sex after a prostatectomy won't be the same as beforehand. You have to look at doing things differently. And I mean, one of the things that I had absolutely no idea about was that males can have an orgasm without an erection. I just didn't know that, because beforehand it wasn't an issue. But so even if you don't end up with an erection, you can actually you can have an orgasm, and so you can do things that will achieve that, which will pleasure, and it will satisfy to an extent, and also make you both feel better. So you don't actually have to have an erection to have that sort of, or penetrative sex to have an orgasm, to have some fun, and you can try and lengthen the penis during the process, etc. So it's worth noting that whatever you do, you should try and do new things, and talk to your partner about what feels good, what should we try next, that sort of thing.
So penile length and intercourse go, forgive the pardon, they go hand in hand, I think. So, have we got any questions from? There's a few blokes down the back. Anybody down the back that wanted to ask anything particularly?
Just a couple of questions. Well, one quick one first is about the injections. I mean, normally, I just wondered, it's not a lifelong thing you're talking about, is it? You're talking about the hope that after, one prescription includes a repeat. So, for example, that would be, 12, right? Now, I don't know, maybe a lot of people will then get another round of that. I don't know. The aim of the exercise, I assume, is to get to the point where you stop doing it.
Yeah.
But then would you still expect to do other things like the pump?
Yeah.
Cialis. I mean, in my case, I had to stop Cialis, for example, because I had a severe reaction to the valve. I mean, it was, I just couldn't do it. Couldn't tolerate. So that saved myself nearly $200 a month. But it was just, yeah. The other thing is, the reality. I suppose the answer is, this has been discussed already a bit. That is, the reality is your sex life might really be pretty much in decline because of age, because of problem a partner may have, and all that sort of thing. so, you know, then you have the operation, so you have to moderate your expectations for it. And it's not to say things can't improve, but it's not like you can expect to go back to what it wasn't before your operation.
Yeah.
I mean, that's most unlikely.
Yeah, look, I think, and without tracking down the front, I think that you make a fair point. I mean, you're never going to get back to what it wasn't. That's exactly right. And I think sometimes we get very hung up on, and perhaps hung up is the wrong word, but we often get tied up and involved in this concept of being able to get back to an amount of erectile function, which is actually a byproduct, I reckon, of you know, maintaining penile length. And if we can get some penile length, then we're doing a good form of rehab on the penis, which, you know, we hope might deliver some erectile function. What was the other thread you?
Well, how long you need to continue with
that's right. So, yep. So.
But I asked the same thing about the pump.
Yep. So.
How long do you continue?
Yep. Good question. So, so Tim, do you want to field the? And I think Ian's mentioned 17 injections. That's probably not unrealistic, I think, for a lot of the blokes we see. But Tim, do you want to talk about the injections? You know, no, it's not ongoing, and perhaps how we might utilise the pump, even once we've completed some form of a rehab, and perhaps even at what point do we declare the rehab a success? You want to perhaps talk about that? I'll take the panellists' viewpoints on that.
So obviously the injections are a big topic because, yes, they've been brought up a few times tonight, and every consult that we have, we often spend a lot of time on the injections themselves. And I know there was a question earlier of, well, are they necessary, are they avoidable? I guess everything's avoidable if you want to, but really the main benefit of it is trying to get to that point where you don't need it. And I know a lot of blokes do end up getting to that point. It might take a year or more, it might take 2 years, it might take longer. Essentially, over time, you should be able to see some kind of improvement where you may see that you're not needing the dose that you did once. Potentially, that might take, it's really difficult to say, everyone's different. The pump is another kettle of fish as well. You might be even 5 years down the track, you have finished all of your rehab as such, and you might be able to get, say, 80% of an erection on your own, but you might not be able to keep it for very long, or you might just want to get to that full 100%. That's where you can utilise the pump after rehab. The rehab part of the pump is more of a daily exercise. It can allow you to have intercourse in a lot of cases, without the need of an injection. However, the erection that you get from it, a lot of you blokes would know, the erection is a little bit different to what you might get with the injection as well. But the main part of the rehab is regaining length, reducing venous leakage, which I don't think I've mentioned tonight, but venous leakage is when you get an erection, you've got that influx of blood into those arteries, but it's not enough to actually close off the veins. So the veins are just leaking blood back into the body, so you can't really maintain that erection. You might be thinking, beauty, this is great, I've got this erection, but if you can't keep it and you can't maintain it long enough to have intercourse, well, you may as well not get it at all. So that's the I guess why we're using them, or how you might be able to utilise it afterwards. But time frame is really, really hard to say.
Kim, have you got any thoughts on duration of these things? I mean, what are you seeing with your patients in terms of at 2 years? Are they looking at needles still, or are they taking tablets, or are they using a pump, or are they coming to you in sheer desperation to get your advice? What are your thoughts?
I think a lot of it depends on how quickly they engage post-op in all of the services. So if they're sort of on board and they're getting in pretty quick, I mean, it's really frustrating if somebody comes in and it's, 2 years post-op and they're saying, well, I hope something was going to happen by now and it still hasn't, and, I better come and talk to you about it. I'm thinking, oh, you should have been here, at least 18 months ago. But it is one of those things. If you come in quickly, then we actually have a much better chance of sort of rehabilitating. It's hard to kind of resuscitate nerves and veins and vessels and everything that's been dormant for that long. So it is very case by case. I'm really reluctant to be able to say, I want to make promises here and this is your expectations, because I just can't. A lot of it depends on, I mean, I do actually see clients who don't need medication, who don't need anything. It's rare. And maybe they are, you know, able to have intercourse with sort of an 80% erection. So we've still got to be realistic about what our expectations are. And we start looking at other options as well. So we're not focusing purely on, if you do not have a rock hard erection, there's no point in having sex. You know, you've got yourself, you've got your partner, and we've got to make sure that we're actually keeping that connection going.
Maureen, have you got any thoughts be it on erectile outcomes or continence even in terms of you know, how long? I know we've kind of covered it, but how much is enough? Like, at what point do we say, okay, that's enough? I think we talked 12 months. Do you see people using your exercises beyond that and still getting benefit?
Yeah, exercises are progressive too. I mean, you might be starting off doing one specific type of exercise for a certain type of frame, certain type of repetitions, but it's not going to stay that way. And it won't be beneficial if it does stay that way. It has to be progressed. So as you get stronger, you need to challenge it more. And if you want to go play golf, you don't want to leak, then you've got to target your exercise to play golf and not leaking. And that's all possible, but it does require a lot of time and dedication. And it's very individual. So I think people will keep improving if they keep doing the exercises, but not just doing the same exercise all the time. Yeah. If you do the same exercise all the time, you're not going to keep improving. So you have to challenge yourself, you have to give yourself new things to do and make it more complicated, make it more functional for you and your type of exercise you're going to do. Like, if you're going to want to walk up a mountain, then you need to have your pelvic floor under control to walk up that mountain. If you just want to walk around the lake and be comfortable not leaking, that's what you want to focus on. So it's very much individual, and challenging your exercise to able to achieve that is what you want to do. So you don't stick to doing the same thing all the time.
Can I ask a quick question on that? More with the incontinence problem. Is the only way to get over the incontinence the pelvic floor, or is there some other? Because I know that the sphincter is damaged when the operation is done. Is that all that you can do to improve the incontinence? Is it just the pelvic floor, or is there something else? Anatomically.
You're into anatomy, aren't you? No.
It's all relevant. That's
there is. There's also the other part of continence training is bladder retraining. Because the bladder, I mean, people's bladders were doing different things before they had surgery.
Yeah.
For some people, if they've had a very enlarged prostate for a long time, their bladders had to force its way out to empty. So it works quite differently from someone that has a normal, relaxed bladder. So they've got a completely different bladder behaviour pattern. So part of it, retaining confidence, is also bladder retraining, which is not just pelvic floor exercises. It's about regaining the capacity and the normal method of emptying your bladder. So that's another part of it.
Maureen, would you care to share a little bit of light on some of the TENS machines and that sort of process that we often hear about? Is there a place for TENS machines?
That's a very interesting question. There's a place for what they call biofeedback, which can be visual biofeedback, which is where I use an ultrasound machine where the gentleman can actually see the muscles working.
Has everyone had, who hasn't had a live ultrasound with the physio? Has anybody not? No. So Maureen, do you want to maybe just elaborate as to...
Okay, well there's two. An ultrasound machine shows up different tissues in a different way. So fluid comes up black on ultrasound, muscles come up fairly white. So you can have a look at a bladder and your pelvic floor muscles in two ways. You can either pop the machine on your tummy, but you need a full bladder for that, which is a bit of a challenge sometimes. Or you can put the ultrasound machine on the perineum. Do you all know what I mean by that? So in behind your testicles. And then you can actually see the muscle work, which gives you I think it's good, positive input to know that actually you're doing it right. So that's one thing. You can also use, there are machines that give you like an auditory input. So when you tighten the muscle correctly, you get like a beep. There are TENS machines where you're putting electrical current in are a little bit not necessarily a good idea, because there's a bit of debate about whether if you had a cancer in that area, whether you should be putting electrical stimulation in that area. So I don't do that, and I think that's part of would be a general tendency not to use electrical stimulation in that area. I mean, you can use electrical stimulation to make a muscle contract, but I don't do it for that particular area, for that particular risk factor.
Fiona, I think that probably covers your question off. So the TENS machine is just a little device. They're often used for pain. They've got little pads often in the pain sense. You put them on across the muscle and it helps muscle contraction and subtle pain. You can find them rectally, a rectal node that goes in that can supposedly help with the pelvic floor. So, but to Maureen's point, watch this space and probably treat it with caution. I don't know where the next question, Don?
I was going to Maureen. And we were getting there, but we didn't get to the end. Went to Al Samurai again, and he said, I can fix it.
Did he?
And a couple of months ago, I had an atom, is it? That's what they call it?
An atom, yeah.
Yeah, whatever it is.
Yep.
Put in, and well, it's 99%. But there was a few sore parts. But it's going to make sense. I've still got to carry this thing around everywhere I go.
So Don's talking about an atom device, which the urologist is a urology solution for incontinence, and it's been quite successful in this case. The thing he's referring to is sitting on as a cushion, a ring cushion. As I'm sure a number of the gentlemen here know, you can be pretty tender down there. So the ring
Percentage.
Yeah, so the ring cushion can be quite useful. You hear really positive stories and you hear some negative stories about Adam, but Don's had a good outcome. Question?
Is there such a concept as an upper limit on the number of injections beyond which you may come to some eventual harm?
A really good question. Tim, would you care to take that one?
So the general recommendation is no more than 3 times a week. You could go on for as long as you would like in terms of years down the track if you wanted to, but not more than 3 times a week. And while you are doing that, you would swap injection sites every time. The idea being that you don't want to be causing any unnecessary scar tissue in the penile shaft, which can then give you something like Peyronie's, where you've got a bit of a bend in the penis, and that could be quite damaging. It can mean that you can't have intercourse as easily. It can mean that your erections might be a bit painful. It can be treated, but yeah, if you can avoid it in the first place, that'd be better.
Yeah, I think what Tim says is spot on, Ross, in that there's no upper limit, and I've been doing this for a fair while now, and I've got more patients than I care to count that they say the injection works all right, I'm happy with it, the wife's happy with it, it's pain-free, it's very predictable, and I'm just going to keep using it. So horses for courses, but there's no particular reason that you can't use them ongoing, as long as we're not getting bending in the penis and scar tissue forming.
Thank you. I just wanted to follow on from what Maureen was saying about, that's the first time I've ever heard about bladder retraining, because I've never had a discussion at all before, and it's probably something that I need, because I had a very large prostate for a long time before I was diagnosed with prostate cancer, and I knew I would eventually have to have something done to the enlarged prostate without the cancer, but it was a late thing. And it's probably, I'm in a situation where my bladder got used to being sort of separated into 2 segments by the prostate. And the thing I find, I mean, the discussion on the erectile dysfunction is all very interesting to me, but I think the most important thing to myself is actually the incontinence, because that's the thing that affects you every minute of the day.
Yes.
And I couldn't care less if I never had another erection in my life, which is not the case with me. I've been lucky enough to have sort of 80% functions virtually straight away, which is pretty, I was really pleased about. But the incontinence part is every day. And that's just something that, like, you say you're trained to walk up a mountain. Well, I walk up mountains, I run, I do all sorts of things. I have to train for every single activity that I do. And that's it's hard to get your mind around that, you know. And but I was really interested that you should talk about bladder retraining, because that's something that I'd never heard of before. So thank you for that.
I've had an enlarged prostate as well before the prostate cancer. And I don't have incontinence, but before I had my prostate out, I used to have to go to the toilet during the night, and often get up, got to the stage drove me mad, and then they gave me some tablets so I'd go less, so I could sleep. And I've had my prostate out. And when I was in hospital, I had the catheters and they piss in the thing. So I've taken one. I've got one, and now if I wake up in the night, I don't have to go all the way to the stand to piss, go back to sleep. And it works fantastic. But I still, not as much maybe, but I still wake up during the night. This is after I've had my prostate out to do a wee. But I've been lucky that I don't have incontinence, and I haven't since I had my prostate out. The only time is when they talk about you can have a bit of discharge.
Like bladder leakage,
Yeah, when you're having an erectile erection. So when you're having some sort of sexual stimulation, and that's got less now, so it doesn't tend to happen. And a lot of things have improved. So, but that's apparently it's normal.
Yes.
So, so that sort of, I didn't have any leakage. I took the pads out on day one, but I had that other things and whatnot. But what I never talked about is anxiety. Like, I've had all this stuff. I've had two major. This prostate was fine. I had another surgery as well. And what I've experienced, I had time off and I've worked all the way through. What I experience now sometimes is anxiety in the mornings. And once I get up and I get in the day, but it's this sort of thing because you've got this stuff in your head about what's going on. You think about it, like, he'll wake up, I hope I don't piss myself today. And I might wake up and think, I'm never going to have a proper erection or something. Whatever it is. Not that that's a conscious thought. It's that sort of thing that comes up.
I think that's a really valid point. I think that probably there's a lot of men in the room that would share that feeling because your life's flipped upside down with this good of a thing, and the reality is that I think when that happens, that trauma, you do get left with some scars. And I think we work a bit with a lady called Natalie who does some psychology as a psychologist, and she talks about life being a melting pot of experience, and from the time you're a little bloke. She often says, Mum and Dad didn't put a seatbelt on your car. That's into the melting pot. That was from 50 years ago, 60, 70 years ago. And that sort of stuff can repeat on you. And I think, from that melting pot idea, yes, the prostate cancer's in that, and it'll jump out and grab you when you least expect it. And it could jump out and grab you every morning. And getting assistance in that respect, I think, is really important. And Greg Hunt identifies that. And, it's all well good for them to throw money at it, but it's a matter of getting it out to the grassroots where the patients need it, and that's another forum in itself. Question?
Talking about scars, so we've heard Ian had a very unpleasant time with the injections. I'm just wondering whether it's possible to get sort of a general feeling about whether that's an unusual experience or whether the injections, and James has had it for 12 months or so.
Yes.
And I just want to know whether that's really been a trauma for you or whether you've sort of adopted that and it's what the general balance is in the community, whether it's awful and you do it or it's not too bad.
Yeah, look, I've been all the way through, so I had a trough in it because I changed from one sort of injection stuff to another, and it seemed to be not as good, and then I went back. But I don't think it is I've worked around some issues so that it's not a necessarily traumatic experience, because what I found if the anxiety, if you build up an anxiety around the injection, you can actually counter it. The injection won't work. So if you get that anxious about it and go, this and then I've got to have sex, and you're in this position where whatever the position where there's a lot of stress about, about how to perform or whatever it is, the injection may not work. It doesn't matter what you do. So there has to be some relaxation around that sort of situation, and so whether that is doing it by yourself and getting used to it, and then going on to doing it with another person, or not in front of the other person, but it does work. As I said, I don't use it as much, but the other things, I think they've talked about tonight. If you don't do anything, that's when you're in trouble. So doing what's required, things do start to come back, And the idea, but the thing is, it might not be to what I want today, but I'm 12 months down the track, and I can have, going to Hodo the first time he goes, oh, you have a nocturnal erection or something. I'm looking at it going, it doesn't move, mate. What are you talking? But 12 months down the track, I have had things like that happen. I mean, it might not be what it used to be when you have a nocturnal erection. It's not the big strong, but these things start happening. But the reason they're happening is possibly because I haven't used the injections, and because I have taken the Cialis and those other things. And I also knows Viagra Ignite can help having a nocturnal erection. So, so I think there are things that not all will explore here, but there are things that can help. And then it's that sort of thing. It'll happen without medication one day. Because they're low doses, but it has happened. So within 12 months, those things happen, and the sexual experiences I have, have been good, on a whole. But as I said, if you build yourself up in a situation, it doesn't matter how much stuff you put in your pants, it might not happen or whatever. So, and then there's the other side of it, but it's not a nightmare experience.
I'm going to put us on notice because I reckon. Can I get a time check? 20 to 9. Okay, we've got the room till 9. There's two things that I do want to cover before we go, and I will take more questions. But the one thing I want to cover, which I'll get to at some point, is the role of exercise in recovery. I think we as humans and as fortunate Australians are very quick to look for the Kuna Matata sort of, you have a problem, you take a pill, you get better. You have another problem, you take a pill, you get better. But I think sometimes we need to look outside of that mentality that we've often got, where you sort of look for the easy option to get the win. And I think that diet and lifestyle plays a part in that. And I'm really interested to particularly talk to Maureen and Jane and Ian, I know, are pretty active in that space. So that's point one that I want to cover. And point two, before we go home tonight, that I'd really like to cover is a question of cost, because you have the prostate removed, there's a lot of cost, with the urologist. You see the pharmacist, there's a lot of cost. You see Maureen, there's cost. You see Kim, there's cost. You see an exercise physiologist, cost. And private health, unfortunately, isn't going to cover all your costs. It's just not, and it never will. But there are some little things that we can do to help with cost. And I think it would be advantageous that we perhaps cover them in probably 5 minutes at the end. So they're the two things I want to get covered. I'll throw the mic again.
Sorry.
Not at all.
Yeah, my question is there's things up there, when we see the urologist, there's a lot of stuff he doesn't tell you. There's that people don't know down the track. Is it the feedback going to get back to Hodo, as gorgeous as he is,
yes,
and all the other urologists? This is stuff that needs to be told to the patient, not just handed a card, and say, go and see this person, but explained a little bit more. I know he's really busy and you wait a couple of hours before you actually get in anyway. So, but
I can talk quite.
yeah.
So Tim and myself, and probably some of the other panellists, as health practitioners, go to different conferences, and I've been fortunate enough to go to a couple of Australian and New Zealand conferences for urologists. They fly out speakers from the US. Tim's been to a couple of prostate cancer conferences, and I know Alison's here as well as a nurse. Alison attends these events. And look, I'll be frank with you. We sit in an auditorium with 500 urologists, and they say, who talks to patients about penile rehabilitation for half an hour? One hand. Who talks 20 minutes? Maybe 2 or 3 hands. How many of you talk for 10 minutes on penile rehabilitation? You might get 20 hands. How many of you talk for 5 or less minutes? or for between 2 to 5 minutes, you might get 100. And how many